The topic is radiofrequency in pancreatic cyst. You diagnose the pancreatic cyst with the previous presentation, and now what to do with this cyst? Maybe we have to destroy it to avoid malignancy in the future. But it's not so easy because it's a complex pathology, and we will see we have argument in favor of radiofrequency, but we have argument also against. Argument in favor is pancreatic cancer. The incidence is increasing over the world. In Europe, we have an incidence which increase of 50% during the last 10 years. And you see pancreatic cancer is everywhere, except maybe in Africa, because probably registry are not good. And probably pancreatic cancer will be the second or the first cause of mortality among all the cancer in the future next year. And you see the incidence. We have yes. And you see the incidence in the United States increase. So we want to do something, and probably IPMN is the target you want to treat. IPMN represents the most common radiographically identifiable precursor lesion for pancreatic adenocarcinoma. And previous presentation, you have signs for malignancy, and in this review, you have the main sign of malignancy, the site size, a thick net enhancing cyst walls, a multiple cyst, a solid component. Of course, if you have a cancer, it's malignancy, so it's obvious. And the main pancreatic dilation, lymph nodes, and or abrupt change in the main pancreatic duct. The main size is the enhancement of mural nodule, and for this localized sign, we want to do something. But But we have a problem. We have IPMN. The problem is concomitant cancer. IPMN will have malignancy in the area of IPMN, but in this publication, we have cancer distant to IPMN. And that is a problem, because if you treat IPMN, you will have cancer. If you treat in the head, the IPMN, you will have cancer in the tail. So what's the interest to treat the IPMN in the head? In this publication, I like this. With Saiwai et al., we have 103 patients with IPMN duct between 1988 and 2006, with a median follow-up of 59 months, a minimum of follow-up of 2 years. And we have 6%, 6 patients, we have 100 patients, is the same number, who develop a pancreatic adenocarcinoma, and 2 patients, 1/3, pancreatic adenoma distant to IPMN. In this, in this very big study with 1,404 patients with IPMN branch duct with a mean follow-up of 6 years, we have a total of 68 cancer in the follow-up, and you have the same number of cancer with derived IPMN cancer and distant, distant cancer, concomitant carcinoma. So that's the problem. And in this study, they failed to find sign of IPMN who can tell you if there will be a distant or IPMN cancer, because if you have 1 IPMN or more than 2 IPMN, it's the same thing. You have the same number of cancer. And you see that is the incidence, even during the follow-up, it's the same percentage of distant cancer and derived IPMN cancer. Okay, but we have another study. That's the advantage in PubMed. We can find what we want, but we have another study in contradiction with this big study. In this study, we have 577 patients with a median follow-up of 82 months. The same risk of malignancy, 5%, so probably the same population, but they have only 4 concomitant cancer with a total of, you see, 20, almost 20 cancer. So maybe we have some hope, and they surgery, they perform surgery also for benign lesion, but that's the life. There was a problem. We are not very good in the diagnosis of cyst. But so we have, maybe we have not only concomitant cancer, and maybe we can target the localized IPMN. The surgeon did it, and they developed a technique with sparing parenchyma. They developed inferior head resection, duodenal preserving pancreatic head resection, modified duodenum preserving pancreatic head resection, in order to preserving the parenchyma. In this study, this surgical study, and the advantage, you have a figure to explain what they do, because we are not a surgeon. Maybe some of you are, but I'm not a surgeon. And they perform sparing parenchyma with enucleation, resection of the uncinate process, or central pancreatectomy. And in their follow-up, they don't have a lot of distant adenocarcinoma. They have 3 patients reoperated with one with microinvasive cancer, but no distant microadenocarcinoma. So a lot of surgeons wanted to perform enucleation, and enucleation carcinology is the same technique from a carcinologic point of view, the same technique of radiofrequency ablation. In radiofrequency ablation, you have no pathology, but you treat you do a local treatment as you do with enucleation. So if enucleation is working, radiofrequency ablation must work. So the surgeon decided to perform enucleation, but you see, we have a small series, 4, 4, 7, in this study by our surgeon. And in the follow-up, they don't have concomitant cancer. In this big study from Germany with 74 enucleation, about more than 100 patients scheduled for enucleation, but they could not perform enucleation for all the patients. They reported their results for 2004 and 2014, sorry, and all patients had IPMN branch duct and pathology. They operated 71 low-grade dysplasia and 3 high-grade dysplasia. And you can see they converted 2 patients who had invasive cancer. So that begins a problem with radiofrequency ablation, because with radiofrequency ablation, you cannot convert your technique. If you do a radiofrequency ablation for invasive cancer, it won't happen very well for the patient. With a median follow-up of 32 months, they had no recurrence and a low morbidity. Sorry for the button. They found factor of relapse, of course, IPMN in the pancreas remnant. We can tell it without literature, it's obvious. And maybe the mural nodule, because maybe mural nodule is not only malignancy on the mural nodule, but maybe it's malignancy close to the mural nodule, and that could be a problem also. The same group from Germany published this year their follow-up, and that's a good thing. You see, 66 patients could be followed up during a median of 87 months. 10 patients had radiologic recurrence, 3 at the local site, 7 at distance site, but IPMN can, it's not the problem, the recurrence of IPMN, the problem is a concomitant cancer without IPMN. And they know they have only, they have no, concomitant cancer. They have one pancreatic cancer distant, but with IPMN associated. So we have some arguments in favor of local treatment is possible. What is the limit for enucleation? Is, but you saw in previous presentation, it's difficult to do a diagnosis of the cyst. Preoperative establishment of a definitive diagnosis of benign IPMN is very difficult using the currently available diagnostic modalities. We have 1 study with long-term follow-up. No long-term recurrence or survival rates are yet available. And the progression to the main pancreatic duct cannot be accurately assessed preoperatively. If you have skip lesion, just a lesion close to the IPMN, you cannot say it preoperatively. It's a surgeon, it's a pathology report who will tell you there is a skip lesion. There is theoretically a risk of rupturing the cyst. And we have some problem of definition during the literature because the definition change. Low-grade dysplasia now is IPMN. You have no IPMN without low-grade dysplasia. It's the definition of the pathology report. And in the literature, sometimes you have a differentiation between IPMN with or without low-grade dysplasia. So it's difficult to understand some papers with this difference. Okay. So once again, the problem is the diagnosis of dysplasia. The problem is who you will treat with your radiofrequency ablation. You see in this surgery series, they have 136 patients with IPMN with stigmata with a follow-up of 29 months. 13 patients developed an indication for surgery. 2 were contraindicated because they were in poor condition. But look at the result of the pathology. 1 pancreatic adenocarcinoma distant for IPMN, 4 IPMN with low-grade dysplasia, so maybe you could follow up this patient. 2 mucinous lesion, so it's a problem of diagnosis from the beginning. 1 endocrine tumor, one of the, maybe it's associated with IPMN. It's possible, but there's a problem also diagnostics. 1 serous adenoma, 1 inflammatory cyst, 1 lymphangioma. You could let in place. You could leave in place without surgery. So is surgery a success? Probably not totally for 1 patient, maybe, but it's our fault. It's the fault of the gastroenterologist who did not do the good diagnosis. I'm sorry, I have some problem with my finger. Ah, yes. So why RFA? Well, the IPMN has a spectrum: low-grade dysplasia, high-grade dysplasia, invasive cancer. So we want to up. No, we want to treat this high-grade dysplasia without invasion, without lymph nodes. That's the target of radiofrequency ablation. Easy. We have to find high-grade dysplasia. We know it's not so easy. The number of patients increase. We saw just previously we detect more and more cysts, so you cannot maybe operate all the patients. And IPMN may become invasive during the follow-up. We are sure we have some IPMN who will become invasive, and surgery does not prevent recurrence totally. Recurrence can develop after surgery evaluated in 1,000 patients operated, and recurrence in this patient is evaluated to 6% and 12.6% after 10 years. And RFA, we are sure have morbidity. So what is the target? That is a sign of prediction of malignancy. What can you do with your RFA? You can target the mural nodule. You cannot target your main pancreatic dilated because you will have an injury of your pancreatic duct on pancreatitis. You cannot target lymph nodes. You will perform a local treatment with metastatic lesion. It's not a good thing. You can target the size, but once again, not the main pancreatic duct. So you have the sites with the mural nodule. But how to be sure it's high-grade dysplasia, we didn't answer. So the technique. Up to 80, partially the cyst. And then your needle is inserted in the cyst, trying to target the nodule. The nodule is here. The nodule is here, so we will begin with a power of 50 watts. And you see the bubbles, and we call that white bubbles. And when it's white, we don't have another sign. We don't know if it's a very good sign, but we have only this sign. When it's white, it means you worked well. So we try to burn all the cysts, but you see the first problem, first technique problem. We do this in the liver, but in the liver, you can insert your needle and burn your cyst all the time you want. It's performed for idiopathic cysts in Egypt, for example, and you burn the cyst like your pasta. You burn the water, and the cyst will burn. But you cannot do that with the pancreas because you will burn your pancreas and create pancreatitis, injury of the pancreatic duct. So you have to minimize your burning. So we burn until it's white, and you see, second problem, you use two needles, one for aspiration and one for radiofrequency. And if you aspirate too much the liquid, you don't see any cyst. And so radiofrequency will be impossible. So to avoid to have liquid was a problem for the radiofrequency of the cyst, it will be a great, you will have one needle. So what is the result in the literature? You will be a bit disappointed because there's no literature. There is free paper. There are 3 papers. One French paper from a multicentric study in which we participated, and 2 other papers, one this year. But you see the number of patients is low, 6 patients, 17, 4 patients. And the result, because you have to empty the cyst, you cannot really target the nodule you want to treat, because it's like the forceps. You cannot go where you want in the cyst. The results are 30%, and in the based on the case, 2/3% for total complete response. To keep in mind, for endocrine tumor, it's almost 100%. So we have a problem of technique. You use different technique to aspirate on performing RFA, and we need a dedicated needle for cyst RFA to progress, at least for the technique. So in conclusion, the ablation of APMN with a minimum of morbidity, that is the case, will be probably the future, sure. But the challenge is which IPMN must be managed with RFA. We have not yet the answer. We have probably no effect on distant adenocarcinoma. We have a limitation. We cannot treat main pancreatic duct IPMN. The advantages is low morbidity, the sparing parenchyma, but the technique must be improved. Thank you.